Good evening, everyone. I'm Dr. Moses Fache. I'm a gynecologist and a fertility specialist. I'm the medical director of Procare Hospital, a frontline fertility hospital in Nigeria and beyond. I'm also a certified member of the International Society for Stem Cells Application, which of course is a body that encompasses the use of stem cells and other cell-based products in regenerative medicine. So I'm going to be talking to you today about a new, more like a recent innovation in fertility management that I think might interest a teeming number of people who are trying to conceive. So without wasting much time, what we are discussing today is ovarian rejuvenation using PRP. Now, that's the common thing people know. PRP is platelet-rich plasma. But what we try to call it on our side is plasma that is rich in growth factors. That is PRGF. As we move along the conversation, you will understand why it is so. So I'm going to go quickly to say that in the beginning was Adam. And God created Eve as a companion to Adam and blessed them and told them to go and multiply and be fruitful. And since then, reproduction has become an integral part of human existence. Truly, looking at the world population today, it seems like we have truly multiplied and subdued the earth. However, one would think that this whole process was going to be seamless. Once a woman finds a right partner, then following this God's command, they're just going to have a seamless journey into reproduction. The reality actually is that about 15% of married couples worldwide suffer from some form of difficulty in conception and may need some form of assistance. Eventually, some people get help, others never get help, and they remain childless. So it is in the bid for humans who are very lucrative and always exploring to overcome this infertility. A lot of experiment researches have gone into infertility, and in 1978 there was a groundbreaking discovery by a scientist, then Robert Edwards and Step 2, who discovered IVF. IVF is in vitro fertilization, and that was to overcome the challenge of inability to conceive based on bilateral tuber blockage. Women who have this condition prior to that time were considered barren and were unable to have children. So with the advent of IVF, it provided an avenue for us to bypass the tubes and be able to fertilize eggs outside of the body. The IVF, that was since 1978, the IVF that we're doing at this time has undergone so much refinement and development. And today it's a very simple and straightforward treatment. In those days, people needed to have laparoscopy to have their eggs retrieved. These days, we're doing ultrasound-guided egg retrieval. There has been a lot of innovation. Now, once the tubes were overcome, along came the problem of male factor, men with challenges with their semen. And it took several years, up until 1992, before ICSI, which is intracytoplasmic sperm injection, came into being, and it provided again an avenue for men who have sperm problems for their sperm to be used to fertilize the woman's egg so that they can have a genetic offspring as well. Now, this is just to provide, a basis for researches and development that have gone into infertility management. At that time, it was also, over time, we see that there had been an increase in the age at first marriage. People used to get married earlier, around age 18, 15, 16, 20. But over time, as the world, became more developed, there is an increase in the age at first marriage. And along the line, we are now beginning to recognize the problem of age-related infertility. What that simply means that you can have a woman who doesn't have any other reason not to be pregnant other than her age. And this can either exist in isolation or exist alongside other conditions. Now, for us to understand what I'm talking about, we need to quickly look at the biology of the female, biology of the female. So, especially as it relates to the eggs. The ovary are tiny structures. Let me go back to this model where you see the ovaries as these tiny structures here. This is the cut surface, so you can see how the ovary looks. And then this is how solid it is. This is the womb. And then these are the tubes. These are the tubes here. So you can see the ovary here. This is the ovary here. So this is where all the eggs that a woman would ever have is stored. And the time of their development that they have the highest number of these eggs is while they are still in their mother's womb. At about 20 weeks of pregnancy, a female fetus or female baby would have about 6 million to 7 million eggs in her ovaries. And from that moment onwards, there is a continuous decline in the number of these eggs, such that when the child is born, at birth, she would have just about 1 million to 2 million eggs in her ovaries. Unfortunately, we do not know why this loss is there, and there is no way, even up until this day, how this loss can be mitigated. This loss would continue even after the girl child is born, up until puberty. Puberty is the beginning of the reproductive age of the woman. And so by the time the woman is seeing her first menses, she would have just about 300,000 to 400,000 in her ovaries. So about average of 400 of this will be ovulated in an average woman's lifetime. The loss would continue up until she gets to menopause, when the store is practically completely depleted, and then the menses would cease, because the event that leads to menstruation is tied around the ovary, egg maturation, and ovulation. So when that process stops, we say the woman had gone into menopause. An average age of menopause at this time is about 50 years. So we also have instances, and because of the conversation, where we say women have gone into premature, developed premature menopause, and that is when it is happening before the age of 40. So now this loss of eggs that we're talking about is kind of inevitable, and there is nothing that is known to man at this time that can prevent this loss. And it doesn't stop whether you're on contraceptive, whether you're pregnant. There is no medication. If there was a way to stop this loss, maybe when we need them, we will probably go back to say, yes, let us allow the eggs to be to go into development. But there is no way to stop this loss. So this is the reality. And so this, again, is the traditional biology we understand, until sometimes in 2004. So women who have this age-related decline are one of the very challenging population when it comes to fertility treatment, because whereas a woman would need just one egg during natural conception to be ovulated and go through the processes and get fertilized and implanted and become a baby, when you are doing IVF, you need to start with good number of eggs to be able to say, okay, yes, optimal number is considered 7 and above, preferably 10 eggs to start an IVF cycle where you are reasonably confident that you're going to end up with a baby. So when you have numbers that are less than that, we begin to talk of diminished ovarian reserve or diminished ovarian response. So this is where many women who find themselves in this situation are currently advised to use donor egg. And that donor egg does not give you a genetic baby. You are going to carry the baby, but that baby is not genetically related to you. And when we consider adoption, we still feel that donor egg. Can you hear me?
Yes, I can.
Okay, so I think it was from your end. So
Yes.
so people are advised to use donor egg, or you can remain childless. Of course, we know that there are also religious and cultural barriers, preventing women from using donor egg, and so it's not an option that everybody would want to take. So research has been going on from using different protocols to see how we can help such women who find themselves in this situation to have genetic babies. So we've had various protocols modified. We've had different adjuvants like growth hormone. We'll talk about DHEA. People buy different kinds of supplements. Majority of these supplements, the claims are not verified. They're just beautifully designed and labeled fertility supplements, and people buy them, maybe even designer supplements. Maybe when they carry names of designers, then people buy them and use them without any claim of efficacy. So this is where we are. So for those who are knowledgeable and have the money, we also give them warning that, if you see that you're getting past certain age and you're not finding the right partner, or you're not ready to settle, then you can also go and freeze your eggs for future use. So, but of course, these are options for women who have anticipation that they may suffer this age-related decline in infertility. At this point, there are so many women. The chance that women between age 40 and 44 have a 30% chance that they may not be able to conceive because of age-related factor alone. And so researches have been going on. We know right from time that even when a woman goes into menopause, there are still about 1,000 of these dormant follicles in her ovaries, but for some reason they are not entering into development, they are not maturing. And in 2004, a groundbreaking research also came to conclude that there is what we call ovarian stem cells in the ovaries that can be stimulated to also develop into female eggs. This research was first done in mice, which of course has similar biology with women, with humans, and then of course there have been attempts to apply it to human. But we know today that when a woman had got into that point where there are ovarian stem cells and then we have some dominant oocytes in her ovaries. So this is the target of the ovarian rejuvenation using PRP. Now, the question to ask is, how did we come into, to know that, okay, PRP does all this? When I was a medical, yes.
If you have any questions, I know I had earlier stated that questions in the question box, but because we inverted the posting of this, I'm not able to access that question box. So please put your questions in the comments, and I'll take screenshots of your questions to be attended to at the end of the session. Yeah, sorry, continue.
All right, thank you. Okay, so how did we come about platelet being useful in this regards? You would realize that when you have an injury, the first thing that happens is, the bleeding, there's bleeding from the injury, And what we know from traditional biology is that these platelets, which are blood cells, just are the first responders that would come in to control the bleeding. That is most of the things we know. We knew platelets as bleeding stoppers. They help to stop bleeding. They come together, what we call platelet aggregation, and then stop the bleeding. What we never really thought about is how do those skin cells, because when you have like a bruise, for instance, it's not just bleeding, it's not just blood vessels that are damaged, the skin, muscle cells, how do they regenerate? Such that at some point that injury is completely healed. So we have come to understand that platelets do much more than just stopping bleeding. Platelets contain several growth factors that orchestrate, the regeneration of the different cells of the body. And so that is where this knowledge came from. And so since 1987, platelet-rich plasma, where you can now concentrate platelets from anybody's blood now, and then with the aim of getting these growth factors to be used in a particular, so it's like concentrate, that's why we call it platelet-rich plasma. So you take somebody's blood, concentrate it, remove the portion that contains the platelet, and then re-inject it. So it's been used by cardiothoracic surgeons in heart surgeries. It's been used by orthopedic surgeons since 1987. Now we have aesthetics cosmetologists using them, people who have baldness, have issues, facial issues, skin regeneration. So it's been applied in so many areas of medicine. And safety profile is established. One of the main reasons is that it is autologous. Autologous means that it is from the same patient. So there is no issue of transmission of infection. You're taking your blood, we're concentrating it, removing that portion where we know that the growth factors are concentrated, and putting it back into an area where it is needed. So in 2016 was the first time during the gathering of the European Society of Human Reproduction annual conference in Finland that a group of gynecologists presented first and foremost their findings of ovarian rejuvenation, where they have come to showcase that there is improvement in women who fall into this category of age-related decline, either because they are more than above 40 years or because they have suffered premature ovarian insufficiency. Some of them have gone into menopause, that when you inject PRP into their ovaries, they tend to recover some of the function, and some of them have gone to conceive naturally. Others have had improvement in their IVF outcome, especially with the number of egg yield and the quality of eggs. Of course, before they presented the study in 2016, that's about 7 years, almost 8 years ago, they have been doing it behind closed doors in their centers, and they saw that yes, this actually has positive effect for them to be able to come into that scientific gathering to present their finding. ESHRE, as we normally call it, is apparently the largest gathering of reproductive specialists all over the world. And so it is not a small gathering of small-minded fertility specialists, it's a worldwide gathering. And so that was presented there. Since then, several other researchers have tried this PRP, and there are several centers in Greece, in Europe, Turkey, in the US that are doing this ovarian rejuvenation, and they have reported very interesting successes. And so that is why, the world is a global village. So the fact that you are here in Nigeria, somebody is doing something, yes, you can key into the knowledge is shared, you know the processes, you follow the processes, replicate it, and then you get similar results, which is the reason why we have come to introduce ovarian rejuvenation using plasma rich in growth factors in Procare Hospital in Nigeria. So that's basically the physiology of using platelet rich in growth, plasma rich in growth factor injected into the ovaries of the women, and then we have seen significant improvement. The challenge is, as at this point, it is, yes. Yes.
Sorry, sir. Okay, I just want to quickly, not all of us are scientists. You and I are very, but we need to sort of break it down like a little bit. You and I are very, very geeky. So let me just put it down in this language in a way that those of us that are not geeky can get what you're saying, because I want everybody to carry that along as much as possible. So please.
Yes.
You mind? 2 seconds. In fact, at this rate, don't answer all the questions I wanted to ask you without being able to open my mouth to ask the question. Okay, so sorry, but yes, just in a nutshell, pretty much we've heard most of what Dr. Fache has to say. What he's generally saying is that this entire PRP thing is using your blood, Abby, Dr. Fache.
Absolutely.
Based on the fact that when we hurt ourselves, normally we bleed, and then that begins a whole new healing process and all of that. So there's been lots of research that has been done, and this entire PRP process has been used and applied in different aspects of medicine. I personally done this as well, but not for ovarian purposes, for more cosmetic postpartum hair loss shedding processes. And like I said, I've explained that before to people, it works. And when Dr. Fache was talking about this process, I knew that it had to be something very, very interesting and that we could definitely look into, and it would serve a lot of, people. Now, the thing is, like you said, the steps to getting to this point have been very, very long. From the first point when IVF was introduced all the way down to 2016, Abby, Dr. Fache.
Yeah, absolutely, yes.
Has been now.
Hello. Hello?
Can you hear me?
Yeah, we lost you for a moment, but yeah.
Okay, sorry about that. Yeah. So, and that's when I did this procedure to Nigeria. First of all, for women that it's hard for them to, you've done IVF multiple times, it's failed, you're having reduced ovarian reserve, etc. This helps in rejuvenating the production of eggs for women that may be approaching menopause or something else is going on with their ovaries, etc., etc., etc. So I hope I've broken it down in this language a bit. Dr. Fache, please write on me. I'm interested.
Yes, basically that's what it is about. So we're looking at population of women who either, who have lost, who have reduced ovarian reserve either before the age of 40. Those are actually one of the people who tend to respond very well. People suffering from premature ovarian insufficiency or ovarian failure. We also know that there are a few people who don't have complete failure, but they have diminished ovarian reserve. So you stimulate them and then they yield just about 3-4 eggs, sometimes 2 eggs. And so they would benefit from this ovarian rejuvenation. Of course, for everything that had come to be, there are people, I tell you, who in Europe, for instance, who are using this procedure not necessarily for pregnancy. They want to have improvement in their menopausal symptoms. And PRP ovarian injection have been seen to compare side by side excellently well with hormone replacement therapy in relieving these postmenopausal symptoms. There are also women who have gone on to conceive naturally because some have had resumption in their menses. They've stopped menstruating maybe a few months to 1 year, and then they get this ovarian rejuvenation, and then they resume their menses. There is worldwide effort, places where this have been done, to limit the age to not more than 50. So this is not something that we want people who have been menopausal for 10 years, 15 years to come and say, oh, come and do me ovarian rejuvenation, because what we are targeting, we're not introducing new cells. We are targeting the cells that are remaining there that for some reason are dormant. They're just, just like some people, they're just following, they're just living, they're just going, so they are not active. So we know that there are some cells in the ovaries that for some reason are not multiplying. So that is what we're using this PRP to reactivate, to reawaken. That's what rejuvenation means. Reawaken sleeping cells. So the ovarian stem cells are reawakened and redirected to develop into oocytes. The remaining dormant oocytes are reawakened to enter into the maturation process. And so in that way, it could increase the number of egg yield. So if you're going to do what we call egg pooling IVF, for instance, where you have to run several cycles to be able to get enough eggs. So if you're going to be running 3-4 cycles and you do ovarian rejuvenation, if your response is good, then you may end up with just about 2 cycles. So that is the concept of ovarian rejuvenation. We are not saying that if you are producing 3 eggs, then you suddenly start producing 20 eggs. There is a modest increase, and that modest increase can go a long way to make the difference between having a genetic baby and then remaining childless, or having to use donor eggs. So this is the concept of ovarian rejuvenation.
Okay, thank you very much, Dr. Fache. Well, I told you now I had a whole long list of questions for you.
Okay.
But in everything that you said, you've answered quite a bit of the questions that I had. You've already explained to us what ovarian rejuvenation PRP is, how it differs from other fertility treatments, and you've also talked to us about the main objective of this treatment in general. One of the things that I think I wanted to ask you, which I never really got around to asking before now, is there something specific? Like, I know people react to treatments in very different ways, right? So what conditions, number one, would make a patient, apart from decreased ovarian reserves and all that, which you've answered, is there something that is specific, maybe specific markers or characteristics in the patient's blood that makes them have a more favorable response to this ovarian PRP? Or is this something that just generally gets very good responses from across board women, as long as they fit that criteria?
Basically, having a general wellness, a healthy lifestyle, there are factors that, of course, would improve the outcome of ovarian rejuvenation. If you don't smoke, if you don't drink alcohol, and then you maintain good weight, good BMI, all this, that's body mass index, would improve your chances. You are not on medication, chronic medication like steroids, that will not allow that will interfere with the effect of the PRP. So these are factors we take into consideration. When you have good level of blood level. So because what we're doing is concentrating your platelets, and we're looking at being able to concentrate between 5 to 10 times what it is normally for us to be able to inject. So if somebody is anemic, for instance, and has low platelet level, even when you concentrate, you may not get that good amount to give you the effects that you need. So anemia could be something that could stand on your way. Now, just to digress a little, I saw a question that says, if a woman has fibroid, can she benefit from ovarian rejuvenation? And I think that is an important area we need to discuss. If we're doing ovarian rejuvenation for the purpose of getting pregnant, then it means that every other part of the reproductive system needs to be in order, because our ultimate goal is somebody is coming to me to do ovarian rejuvenation. You have a fibroid that is not going to allow you to conceive. So even if we have the best result from ovarian rejuvenation as shown by some of our parameters we use to assess improvement, that woman is not likely to get pregnant because there are other factors. If you do ovarian rejuvenation and your husband has low sperm count, then you cannot get pregnant. If you do ovarian rejuvenation and you have blocked tubes which have not been diagnosed, then even if your ovaries are producing good number of eggs, you can't get pregnant. So see people just call and say, oh, can I come and have ovarian rejuvenation? And they try to forget this aspect. Ovarian rejuvenation, I mean, when it comes to fertility, treatment is more like, something that can support your IVF outcome. And some women are lucky if the only reason that they are not getting pregnant is because of egg depletion. Yes, if they respond well, they can go on to have natural conception. So it is not entirely, can you hear me? Hello?
Yes, I can hear you, doctor.
All right. So it's not an entirely a replacement for IVF, because I've also gotten people asked. Got people ask me that question. Says, okay, do I still need to do IVF? So they need to understand that yes, when we have these people, most of these people we're talking about, diminished ovarian reserve, a lot of them are already in for IVF and they've been told that they need to use donor egg or nothing. And so when you do your rejuvenation is to improve your outcome, that IVF. So now, because if the problem is, we can't get good number of eggs, then if you're doing something that may improve your egg outcome, then yes, it can help you, help your IVF processes. And yeah, we also have had patients who failed IVF and gotten pregnant from a natural conception. So all this, they go hand in hand. So it's not like, okay, somebody needs to do IVF and say, okay, now I'm not doing IVF again, I'm going to do ovarian rejuvenation. So we need to make that very clearly, that it can improve your outcome. And then you need to work hand in hand with your doctor. If you have other factors that can impede conception, they need to be sorted. If you have a uterus that has scar tissue within it, that needs to be sorted, except if you are doing rejuvenation for a surrogate to carry your baby. So you cannot do, of course, we also apply PRP in the uterus. So I'm sure in the course eventually we may. So let me let you ask that question so that I can answer.
Yeah.
Mm-hmm.
I was about to ask you that question because in the process of my research, I stumbled across information that PRP is used, even applied to other forms of reproduction, to the enhancement of reproduction in other ways.
Mm-hmm.
I don't know to what extent, you're the expert, so perhaps you'd answer us now. I heard it's being used in improving sperm quality or is it count or quality or motility, or I don't know, you know the terms. And I've also heard that it's being, or I read that it could be applied to the endometrial, like endometriosis or something. So I don't know to what extent those are correct pieces of information and to what extent those are also being applied, whether in Nigeria by you or anyone else. And I ask this, I say in Nigeria part because I remember 3 months ago or so when I first stumbled upon this ovarian rejuvenation thing you were doing, all of a sudden I also still started seeing some other hospitals that were speaking up and saying that, oh, they do this and they do that. So we have a whole lot of women on here, and everything I try to do, especially with women in the community, is aimed at reducing the risk of exploitation as well. So one of the other questions I'm going to come to you with is what women should look out for, because we know this procedure is relatively recent, and we know that not many people in Nigeria are doing it, although many people will claim that they can do it just because. So this is also an avenue for wider education of the women as well as to what they should look out for. So in this one question, I have two questions. Number one, is it applicable? Can you use it on sperm, endometrium, and all of that? And then secondly, what should women also look out for when they're looking for specialists that handle this issue, especially in Nigeria, so they don't enter us?
Okay. No, I would ask, the use of PRP in reproductive science started even with the uterus before it got to the ovary. So there is more widespread experience with endometrial rejuvenation than yes, where there are times, when we do this IVF, there are people that no matter the amount of medication you give them, their lining would just refuse to grow. And yes, there is a cutoff point. Like we feel that if the lining of the womb is not up to 7 millimeters or higher, and you transfer embryos into that lining, the likelihood of pregnancy is almost zero. So PRP have come to be used, in such patients, and we have seen very significant positive results. In fact, that is, it's getting more universally accepted now, that PRP for endometrial rejuvenation, because what we're thinking is, even in uterus that the lining is scarred, once you have, normal endometrial patches here and there, this PRP goes to stimulate them, because like I said in the introduction, it contains growth factors that helps it to orchestrate, it's like an orchestra, directing, hey, you go here, hey, you do this and that. And at the end of the day, we're seeing improvement, and we've applied it a lot in thin endometrium and in cases of intrauterine scar tissues. Now, one thing that you would see with PRP is its versatility and the very good safety profile. So it gives this opportunity for people to apply it into various parts. And of course, just like I said previously, I try to give a rundown of IVF, how it came, and the development that have gone into it. Over time, we would realize that, okay, this PRP has become applicable. First, it was, mostly surgeons, orthopedic surgeons. Now, people are using it for hair growth. Imagine that somebody has a bald head. There are hair follicles there, but for some reason, they are not producing hair. So you inject this, PRP, and all of a sudden, this hair follicles that refuse to be active over a long period of time start producing hair. That is a very visible action. That's exactly how we think is also operating in the ovary. That there are cells there who, for some reason, are not active, and then you put your PRP there, it goes to activate them. Same thing with the endometrium. Now, we apply it to the testes, but there hasn't been so much experience with the outcome in men who have semen abnormalities. But yes, there are efforts to also, if it's good for the women, couldn't it be okay? Will it not be okay for the man? So, and all these researches we're talking about were done in centers. And the important thing is get your consent. Let the person know that, okay, this now you're taking advantage of the safety profile. It may not cause so much good, but it's definitely not going to cause harm. Our first principle in medicine is first do no harm. So for anything we're going to be using, we would let the patient know. So it's not like, we'll let you know this is what we're doing. It may have beneficial effect. And that's the counsel we give to women who are coming for ovarian rejuvenation. We tell them, this is relatively new, so it's too early to begin to say, oh, success rate, because as you can see from the presentation, there are a wide variety of women that may need this ovarian PRP. It's not like infertility that you just know that, okay, infertility is infertility, but when it comes to, there are different reasons why women may require ovarian PRP. So and it's just beginning. In science, it's not like herbal medicine where somebody can put leaves together or powder and come to the market and say, okay, this can cure it, it can do this, and everybody, people buy it and go and use. When you bring your research to the scientific community, you're talking to intellectuals, they are going to ask you questions over and over and over again. Even if you shoot somebody and the person that, they're going to ask you, are you sure it was your bullet that killed the person? Maybe what if the person... So this is how this, research, that's why when things come into the scientific community, it goes through a lot of rigorous, question and answer here and there, people trying to replicate this research and see, do we have the same result? Could it be different from the way it affects the white people? Is it different from the way it's going to affect the black people? Those are questions we'll be answering in the future when we have enough number that we're also going to be able to go to that X-ray and present our data coming from Africa, for instance. Okay, this is our experience with ovarian PRP. So this is where we are in terms of using PRP, for treatment, both in the endometrium, which is the lining of the womb, and the ovary, and of course, occasionally in the testes. So going back to your second question, when we started this ovarian PRP, before we started, of course, at Procare, everything we want to do, we want to be excellent about it. So first of all, we sought out these centers that are already doing it in the European countries. I just got back from Turkey a few days ago, attending the International Society, the World Congress of the International Society for Stem Cells Application, which is quite one of the highest bodies promoting in regenerative medicine, promoting the use of stem cells and cellular-based products. And that gives you a level of certification to be able to apply cellular-based products. So this is what we do. And so we know that whatever we are doing, we have scientific basis. We've seen what is being done elsewhere. We know the processes, we follow the processes to the latter, and then we look out for the outcome. Yes, we're in a place where laws are a bit not very, I don't know how to put it, but I have seen a patient who came to me and said, she came to make inquiry about this ovarian rejuvenation, and she told me that she already has donor eggs in a particular hospital, cryopreserved, and so she heard about this. She came to make inquiry, and so when she got, we spoke to her, and then she told me that when she heard about it and she wanted to come, she went to speak with her doctor, and then the doctor suddenly said, "Oh, they also offer this ovarian rejuvenation." And then she says, if you do it, why didn't you tell me earlier until I came back to ask you? So these are some of the things. Yes, you're going to be seeing people who are claiming to do this, or you can ask. I always encourage my patient to ask questions. He who pays the piper dictates the tune. So if you're paying for service, if I go to a supermarket and I buy something, I want to ask, is this good enough? So you should be able to ask your doctor, do you have the experience? And then people would understand that at this time, for instance, we haven't had so much number of patients that we're going to say, we have done 500 and 200 of them are pregnant. We are gathering, but we do well to let patients know this is your expectation, truthfully. And then it is something, when you get to that point where it's either you do something or you are left childless, then that is the point where you may consider if this ovarian rejuvenation is for you. If you belong to a particular religion that does not allow you to use donor, if you have a culture that does not allow you to use donor, and the only option you have at that point is to remain childless, then people spend a lot of money buying supplements. I haven't heard, when women come, they bring a ton of supplements from their bag. People who are trying to conceive that have these issues of egg quantity, and quality, and they never ask the shops whether the success rate of this supplement. So they just see it online with all the stamps there, FDA approved. Some don't even have FDA approval. FDA approval does not mean efficacy. It just guarantees real, safety. And so we are doing this and letting people know this is what it is. Other people have done it. They've gotten it, has been useful to some people. Not everybody who have ovarian rejuvenation, there's no guarantee. Even IVF is not guaranteed, but we let people know truthfully, this is what it is. So if you get to that point where you're going to say, oh, I think I need to give up and remain childless, then this is one step further that you can take, to see if it works for you. So this is where my response to your question.
Okay. We've gone we've covered some ground, so I wanted to quickly throw some of the questions that the people in the audience have been asking, just so that we're able to respond to them as quickly as possible. First of all, I've been seeing a lot of questions asking whether the session will be saved. We will try to save the questions as much as possible. We will post it, hoping Instagram is merciful to us. We will post it on both profiles, both Procare and Result the Bell, so you can go back and have a look at it in the future. We'll try to do that, but of course, if Instagram logs us out immediately, then there's not much we can do about it. That's why it's important to stay and just follow along all through. Okay, Dr. Fache. One of the questions someone here is asking is, why do people go through multiple IVF failures? And I guess by just following up on that, the next question would be whether ovarian PRP can help reduce the rate of failure of IVF. You've answered that question, but maybe just another quick response just to knock that one out of the park.
Yeah, what I can tell you, like I said, is that PRP, as the general terms applies, I would tell you that PRP, as it is used commonly, maybe in the cosmetic salons, for instance, what we use in reproductive medicine has gone through significant refinement, including activation. Most times you go to the salons, for instance, they just follow the techniques. They have kits. We have different kind of kits like this one. These are ready-made kits like this one. I don't know if you can see them clearly. That just help you to increase your platelet yield. And then you get what I mean. So usually after we concentrate the platelet, we run the sample again to know how much concentration we have gotten, and we know what we are putting in. So like I said, if you're going to run fewer cycles to get the same number, then definitely PRP is good for you. If one of the reasons why you're having challenge getting pregnant is because something is wrong with the lining of your womb, and we're going to apply this PRP, yes, it can improve your chance of conception. So if you get to that point where you have also been given option by your clinic to say, okay, it is either donor or nothing, then you may consider, is this something worthwhile to try? So that's what we're looking at. So multiple IVF failures, if it is related to egg quantity and sometimes egg quality, because there are also research evidence now that is supporting the fact that PRP can also, in a way, improve the quality of the oocytes. And so, yes, I think for people who find themselves in that category, having repeated IVF failure and uterine factor, diminished ovarian reserve, they really would need to try this. So I think it's something to try before you throw in the towel to say, I can't, I'm giving up on this.
Yeah. Okay, thank thank you for that. The other question I have here, I have another one. I don't really understand the question, but I'll just read it out to you. It's talking about someone who's done PRP on his knee for ACL and meniscus repair. And they're asking, in this condition, what is the case? I don't get the question, but you're a doctor. Perhaps you understand what he's trying to ask.
I talked about the evolution of PRP in medicine and the fact that it is quite commonly used by the orthopedic surgeon, and many people have had surgeries waived because of PRP injection into their joints. That's probably what the person is saying. So PRP injected into joints can help, in such cases, but like everything, assessment it's not like every time you need to do surgery, then it must be PRP. The orthopedic surgeons will assess and then be able to guide you whether this approach will be okay or you truly need surgery. But they have reported that's one of the areas where there have been a robust experience with PRP, especially with the safety profile, because they practically inject it in virtually every joint of the body, and successes have been reported from using PRP in orthopedic surgery.
Okay, thank you for that. There's also someone here who wants to know if you use both stem cells and growth hormone factors, which have been proven to be more effective in the treatment of in ovarian rejuvenation for women above 40, or do you just use PRP? Are you utilizing stem cells as well in addition to PRP, or is that something that's going to come further down along the line?
You see that the topic of this conversation was plasma rich in growth factors, and it was deliberate. I mentioned in the beginning that we didn't, we're just calling PRP because that's what everybody understands. But this PRP has undergone a lot of improvement. We have what we call enriched plasma factors. There is a center in the US that have had, in fact, they are doing their 5th generation of PRP because they have what they call the PRP Ultra, they have PRP Ultimate, they have Generation R. This is different formulations of PRP. So you can have the traditional PRP where you just concentrate the PRP and inject it where you want to inject it. You can have the PRP activated outside of the body. Okay? And then when you activate it, then you kind of allow it to release the growth factors, all the growth factors in it. That is found to be more effective than the traditional PRP. And then when you combine this activated PRP, the growth factors, and then the traditional PRP, it gives you what we call the PRP Ultra. Now we have other elements which we add. The difference between Ghana jollof and Nigerian jollof rice is those other elements that go into it. So we don't just do PRP because especially the ovary is not a place that you want to be going in and out. So we want to be able to go in once and be able to deliver something that we know have the capacity to do what we want to do. And if the person does not respond, we are definitely sure that it's not because of what she got. It's just the fact that it's not working for her. That is our principle at Procare. We're not experimenting. We want to be able to be sure that yes, you're getting the best that you can get. If it works for you, to God be the glory. If it doesn't work, you get a counsel in the beginning. So okay, this is where it is. In the future, more research, as more people are embracing the use of PRP, we do population studies, and then of course refinements are going into it. Like I told you, there's already places where they are doing their 5th generation of PRP, and they use them differently for different patients. So the world is a global village. Eventually this knowledge will spread around, and then every other person gets to have those variants of PRP. So that's what we're doing. So we're using, that's why I showed different kind of kit. You can see this is one kit that gives you, some form of, and this is another one. This is another one. So all these contain, they give you different kind of, forms of platelet-rich plasma.
Okay, thank you so much, Dr. Fache. Thank you. See, we're learning. I told you I was going to be all geeked out by the end of today. I'm very excited.
Thank you.
Okay, so I have another question here. Someone wants to know how long does the process take? And I'll add another question to that question, because another person wants to know whether this is a permanent solution or is it continuous? Does someone have to do it multiple times for it to give results, or can someone just do a one-off and have a permanent solution to their problem? And how long does the process take?
Okay, aside the initial evaluation, like I told you, if the aim of doing ovarian PRP is for fertility, then we need to be sure that every other thing is sorted, because our main focus then will be to increase the number of eggs and possibly the quality. So we need to be sure. So if those evaluations are done, the actual process of ovarian PRP injection is, it's a decade from coming to the hospital to taking blood and preparing PRP from it. Is about maybe 1-2 hours, and then the injection into the ovary is quite similar to the egg collection process during IVF. So it's a day case. You come in the morning most of the time, and by 12 o'clock, most of our patients have gone back home. We do it under sedation at this time, and so the reason why they're staying for, maybe 12, 1, 2 is because after the procedure, we just let them rest in the hospital for like 1-2 hours before they go home. So that is it for a session of PRP injection. Now, I also mentioned that the use of ovarian PRP is relatively new, so to say. Even though it's been since 2016, there are still, not too, compared to some other treatment, there's still some aspect of it that is not standardized. Even the preparation of the PRP, as simple as it is, how much blood do you take, how much speed do you run it, when you need to separate the components, how long do you keep it? All these are not yet standard. So there is no one size fits all. So when you look at all that people are doing, you choose what works for you. These kits that you're seeing, that I'm showing you, they have different speeds. They have different timing for them to be able to give you what you need. And then so it is difficult to compare, like sometimes what the other person is doing in their center, because what you are doing is different from what the person is doing. So we also have parameters. Hormone like anti-Mullerian hormone is one of the key parameters that we use to follow up on the response of ovarian rejuvenation. Antral follicle count, which is an ultrasound guided procedure, is also one of the parameters that we use. Sometimes we add follicle stimulating hormone and estrogen. And so these are parameters that we measure, aside from looking out for like, oh, we will be happy to hear that this person is pregnant. But when we're looking at IVF, these are parameters that we see. And then we say, okay, there is improvement, there is no improvement. There are centers that do multiple injections. Like you come in every 4 weeks, maybe up to a session, 3 times, they are injecting ovarian PRP. And there are centers we just do one, like most centers will do. And then we follow up to see, because when you look at the length of time it takes an egg to start from what we call the primordial follicle, which is the most native form of the egg, to the pre-antral follicle or the pre-ovulatory follicle, it takes more than 3 months sometimes. So we allow that period to pass to see what the response is. So most times, if in 6 months there is no response, then you might opt to have another PRP injection, or you can, work out to say, okay, this is not working for you. So these are the various ways that PRP is being used: multiple injection versus single injection, and then the length of time between taking the PRP and then going for your next IVF stimulation. All those are some of the things that over time may get standardized, so that, okay, if you hear that Center A is doing ovarian PRP, you would know that it's similar to what Center B is doing. You know that even in IVF that has been over 40 years old, people still have different protocols, and newer protocols are coming. Newer stimulation. Every time we are hearing, as we go for scientific conferences, people are trying things differently, just to be able to say, okay, if IVF requires remove egg and mix with sperm and I have embryo, why can't I just put it back and get pregnant? Why do I have to be anxious for 2 weeks and end up not getting pregnant? So this is the question that we're asking. And so research is ongoing to say, okay, this IVF, we have found it. So where do we have the impediments? How can we increase the success rate? And I tell you, the success rate we're having today is way, 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 way better than what it was 10 years ago, 20 years ago, 30 years ago. And we feel that in another 10 years, there will be a lot of advancement in this, fertility treatment.
Dr. Fache, I just want to quickly go back to one of the questions I asked before we move forward. Someone's saying that perhaps we didn't hear, you asked whether you use stem cells in Nigeria for older women. She says you only talked about growth.
Oh, yes. Yes, there are different stem cells. There are, caution when you're using human stem cells for ovarian rejuvenation. Now, when you talk of stem cells, there are various forms of stem cells. Stem cells are cells that have the capacity. They are very native. So if you put it in your hair, then they can begin to develop hair. If you put it in your eyes, they can begin to develop eye. If you put it in your... So that is what stem cells means. And there is concern, especially when it comes to ovarian rejuvenation, using such human source stem cell like mesenchymal stem cells, or what we call embryonic stem cells, like you can get from the umbilical cord or placenta, for instance. That what if you put it there and it develops into cancer cells? That is one. And so unlike PRP, that is just going to reactivate what is already there. This thing is already destined to be hair, but is not responding. So we try to activate it. It's different from using stem cell that you're putting in an area, hoping that it's going to develop into oocyte, and the stem cell say, hey guy, I don't understand the instruction. I think, just like I forgot the question now, the stem cell may also forget the instruction and decide to say, man, I think I want to become a cancer cell. So that is where, and so you see that, like I said, this PRP, places like US, there are several centers in the US, in European countries, because it is taking something from one part of your body and putting it in another, does not really require any special regulation per se. So there's nobody talking about FDA approval or whatever. But stem cells have strong, regulation. In most countries, you can't just use stem cells because of this concern. Now, one of the things that we have done in the regenerative medicine arena is to go further to develop what we call exosomes. Exosomes are smaller particles that have the capacity to do even beyond PRP, as it were. And yes, so that is, the exosomes, is the future. It will be the future of regenerative medicine, and so it doesn't have this similar quality with stem cells. So, and of course, it requires a lot of laborious effort to be able to extract it. There is There are few centers in Turkey that are producing these exosomes, and because of what it takes to produce them, they are quite expensive, but then they are very beautiful. So the other aspect we're looking at is using plant stem cells from plant origin. Yes. So you may have seen things like double stem cell, STC. Not to promote any brand, but these are stem cells of plant origin. They call them stem cell, not necessarily because they act like stem cell, but they have the capacity to improve the environment. If if everything is, or if your environment matters. So it's not just like, okay, these oocytes are there. So when we try to do ovarian stimulation, for instance, we're trying to be sure, are there other hormones? Like we saw prolactin, how is it? We want to check the thyroid stimulating. That's because we know that there are other factors aside the main egg that we want that can affect our treatment, and we want to put them in order. So these plant-based products, some of them have been found to actually potentiate the effect of this PRP. And so, yes, so.
Okay, so in a nutshell, if I'm just going to answer the person that's been asking, it is for now generally safer when you use PRP, as it were, but stem cell requires the introduction of other things that may or may not, still needs a lot of research, which is what people are all working on.
Absolutely.
Trying to get it right. But now PRP is the safest option.
Yes.
However, with PRP, there is no one-size-fits-all approach to it, which is the reason why you need to go to an expert, and someone who understands all of this. So the application you're getting in your knee, in your hair, in your face, and all of that is not necessarily the same sort of formulation or application that is going to be used when you're doing ovarian rejuvenation.
Absolutely.
From one practice to another changes, and from one case to another changes.
Absolutely.
Yeah. So, Dr. Fache, I knew this was going to be a problem, that we were going to end up staying for more than an hour and a half. I think we're about 10-15 minutes away from our hour and a half mark. So what I'm going to do is just shoot out a few more questions to you. I'm looking through all the questions that we have, and we have them almost 100 questions, which would be impossible for us to get through all of them at this particular point in time. So for everyone here who is watching, if I don't get round to answering your questions, what we're going to do is that I will compile all of these questions that you asked. I'll compile them, and we will have a repeat session in a week's time, where Dr. Fache would then break down and answer each and every one of your questions. But for now, Dr. Fache, let me just, somebody wants to know, can this have positive effects on men with azoospermia or oligospermia?
Okay, before I answer your question, please also encourage your followers, because if they go onto our social handle, they're going to find some responses. Literally, we're putting more information about this on our social media handles and websites, so that some of their questions would can already be answered. Like I said, the experience is more first with endometrial rejuvenation, and then to ovarian rejuvenation. There are also aspects of cosmetic gynecology where we are also using this PRP. I'm sure you've heard things like O-shots, P-shots, and they are all PRP-based events, vaginal rejuvenation. We are doing, these are all things we do with PRP. Alongside, we have a session of, for cosmetic gynecology in the hospital, for instance. Now, the experience in the testes is not as robust. So, we cannot just apply this, to people because there is no, the literature is not very robust on testicular PRP. However, it takes one person. It's a good things comes to those who wait, but better things come to those who act, and the best things come to those who innovate. So yes, if you speak, counsel someone's okay. You are, at this point, if you do this, we are very certain about the safety profile of PRP, and the patient consents willingly, understanding that there may or may not be response. Yes, we have had a few patients that we've had to do testicular PRP, and we're still, following up on them to see what the response is. In medicine, you don't have one response and jump to say, oh, this is okay. We need to have done this on several patients before we are able to say, yes, we have done this, we've seen positive effect, or there is no effect at all. And that's at that point we're able to speak categorically on testicular PRP.
Okay, thank you for that. Also, I'm going to think they are all related. A lot of people have been asking here whether it can help women with implantation or endometrial issues, and also women that are suffering from polycystic ovary syndrome as well. So women that have agitation, and someone even asked about women with blocked tubes, fibroids, polyps. Are they able to do this and still get pregnant? I know that you answered, you made mention of this before, but these questions keep coming up again. So if you could just give us a brief response to this, we can expatiate more on that.
Yeah, for endometrial rejuvenation, recurrent implantation failure, the answer is definitely yes. PRP is useful. Blocked tubes, no. What else did you ask? Uterine fibroids, no. Polyps, no. Polycystic ovary syndrome, yes. Research is also beginning, similar to what we have in testicular PRP, for instance. There has not been robust research on use with people with polycystic ovary syndrome. But like I said, because of the safety profile of PRP, I can bet you that there are people who are quietly doing some of these researches, maybe on animals, for instance, before they come up to human to say, okay, yes, this is the status of PRP in patients with polycystic ovary syndrome.
So the next question I was going to ask is the exact same thing. Someone wants to know what are the potential side effects of PRP. I know you mentioned that already, but just a quick response to those who weren't here when you mentioned that.
Basically, it's a very versatile and safe product, especially if you're doing it with somebody who understands the use. The risk of transmitting infection is practically zero. But that does not mean that if the handling of the preparation is not done with utmost carefulness, that you cannot introduce like bacterial infection. The infection we're talking about is here, you can't take HIV from one person to another, hepatitis, all those blood-borne infection, because you're taking the patient's blood and preparing this. So, and because of the growth factors in the PRP itself, it also have capacity to reduce the incidence of infection. So basically, pain, would have been one of the things, pain of taking injection, and so that's basically the side effect. So it's almost as saying that there is nothing significant. There's no significant side effect with PRP injection. And then, of course, when it comes to the ovary is not like the scalp or the face where you are seeing and you're injecting. So this is not something you go to maybe someone who is not very conversant with ultrasound and be able to, because it's ultrasound guided. So it's not a blind procedure. So you cannot inject PRP into the ovaries if you are not very good with transvaginal ultrasonography, for instance, to be able to locate the ovaries. And somehow the ovaries are located in between very significant blood vessels. That if you miss the ovaries, you can go into those vessels and you just kill the patient. So it's not that simple the way we're saying ovarian PRP. You need to have very good resolution ultrasound, more like HD screen ultrasound machine, and have the skill as well to be able to say, oh, this is ovary, this is not intestine. You cannot be poking somebody's intestine, especially when we're talking about women who are close to menopause that no longer have antral follicles. You may not be able to locate the ovaries easily, and that is one of the reasons why we have to do ultrasound in the preparatory phase, to be able to determine that yes, we can assess the ovaries easily. You don't just take somebody to inject PRP. You need to have done this more like a mock thing. Let us assume that this is the day of the injection. Can we find your ovaries? And sometimes we are doing videos when we are doing this evaluation, so that when we get to that day, the videos we're recording would help us to say, okay, this was where we saw the ovary, so go there. So it's what happens behind the scene is a lot of complex procedure, but if it is done well by an expert, complications and side effects are quite minimal. Of course, there are post-op instructions, certain medications that you may not be able to take. There are people who, like some painkillers, what we call the non-steroidal painkillers like ibuprofen, diclofenac, for instance. Those you may not be able to take them for a period of maybe even up to 8 weeks.
Wow. Doctor and his team, a lot of people, although I think I may know the answer to this one, a lot of people are asking, well, he did answer the question of how often it can be done. He said it depends. Dr. Fache, somebody is asking how often it can be done, but I believe he said it depends on the person's body response, right?
Yeah, I think, going forward, let people join in at the right time and stay in if they want to follow the live, because I see a lot of questions that have been discussed and then coming up, and so, yeah, you haven't. Yeah, we've talked about extensively about the fact that you can do this as a one-off procedure, or you can do it as a repeated procedure. There are centers, that are doing it. Some people do 2 back-to-back, some people do 3 back-to-back, some people just do once and then follow up to see how the woman is responding. There is no literature at this time to say which one is better among these various options, whether you want to do single injection, multiple injection. We do not as yet have any literature to say, oh, this is better than. More is not always better.
Okay, a lot of people have been asking questions around the cost of the procedure.
I'm also able to see the screen, and I see that there have been responses to some of those questions. I am not one who want to discuss cost on. This is basically to educate people, to let people know that this treatment option now exists and is available. There are numbers you can call to make inquiries about what. You can get more detailed information about what it entails, and then the cost implication. What I can tell you is that the cost of what we're charging here is about 1/3 of what you would pay maybe in countries like the US or Europe.
And you can also you have access to the Procare hospital page, so you can go on the page. A lot of times I have people coming to my DM and saying they want to see doctor. Their contact number is on the page, and then at the same time as well, you can reach out to them, DM them on their Instagram handle as well, and request to book an appointment with the doctor. There are so many different avenues that are open to you. Dr. Fache, I think I'm going to round today's question session off with one question, only because I'm going to pick this question even if she came late, but because this is a question that I would have asked had I not had my own little miracle. And that is, what can cause recurrent implantation failure when the embryo was transferred and blastocyst, the endometrium lining was okay according to the doctor? I know this has nothing to do with ovarian PRP. Bear with me, but this was my story. So if you could just round off with this, and then we plan for the next one.
Yes, implantation is one of the aspects of IVF that is still very elusive, and a lot of research is also going into that area where we have supposedly good quality embryo, the uterus looks okay, but there is more to that. The uterus, as it were, for instance, is not just a dormant receptor. There are activities going on, and so even with ultrasound now we're doing what we call, there are different tests. People have done things like endometrial scratch. People have done, there's what we call ERA test, endometrial receptivity assay, just to be able to determine that point when the uterus is mostly receptive, because it is difficult to understand why you put in back blastocyst, embryo that seem to be okay, and the uterus looks okay, and the patient does not get pregnant, which is one of the reasons why on this side of the divide we're still putting more than one embryo anyway. We're not actually putting those embryos because we want patients to have twins or triplets or quadruplets. It's in a way to improve their chance of conception, hoping that at least if one embryo is not competent, maybe the other one will be. And that is how we have come up with having some multiple pregnancies. I also need to say at this point that most of the IVF that we do, when we say, oh, you have blastocyst, these embryos have developed the way they are supposed to develop, it is on record that when you subject these blastocysts to further testing, what we call pre-implantation genetic testing, more than half of them are not euploid. They do not contain the normal chromosomal complement. So what it means is that when we start doing embryo culture, maybe you are culturing like 8 embryos. On day 5, for instance, you find that only 2 or 3 have made it to blastocyst. The other ones got arrested, or they are slow in their processes. Of course, at this time, we can't keep embryos beyond 7 days. But what it means is that maybe if you have kept the embryos a bit longer, even those blastocysts will not have made it. So as much as we try looking at our processes to say, oh, everything looks okay, oh, madam, yes, we are usually all excited on the day of transfer to say, oh, madam, you have 3 good blastocysts, grade A, grade B, depending on whatever classification. We know deep down that there is something that will need to be done that we cannot do. Reason being that it is very expensive. If people are struggling to look for 1 million to do IVF, how do you tell them to give you 7 million to do one cycle, and you are not giving them guarantee that at the end of the day, because when you do that, your PGT, spending the money after spending that money, you can come out with a result that says all the embryos you sent to us for testing are abnormal. So there may not even be transfer in the first instance. So these are some of the nitty-gritties that patients do not understand. That we as practitioners, we are also trying to help their emotion and not tell you that, oh, madam, you have this blastocyst, and so we don't know, we're just going to transfer it, it may or it may not work. So we try to just encourage people to be hopeful so that 2 weeks wait is not only the patient that waits, so even the doctors, everybody in the fertility team are anxious. So it means that for a center like ours that is busy, if many of us are not hypertensive, is the grace of God, because we have constantly patients that are on their 2 weeks wait that we are praying for. You wake up at night and one patient's treatment cross your mind and your feet. Sometimes it's short of crying. I have team members who cry when results fail, because this emotion. You know. Yeah, so these are things that, so when patients ask you, doctor, what have this and that, the processes are usually right. So which makes it important, choose the right specialist so that when it fails, you know that, okay, they have done their bit, they have done their processes. It is not very easy for us to tell patient it's your fault that it didn't work. The way patient just try to look at the doctor and say, hey, doctor, why didn't it work? So we try to still take all this in and encourage the patient to say, okay, just try again. We know that there are factors. Some people have scar tissues in their womb, and no matter how many hysteroscopies you do, you may never get to improve that, and they are not open to doing surrogacy because they might not even have the money. So these are all the factors. These are all factors, and there are times that the recurrent implantation failure is as a result of the immune response of the patient. So sometimes you have to use things like intralipids, IVIG, to suppress the patient's immunity at the time of transfer. Sometimes it works, sometimes it doesn't work. And so there is a lot that happens with recurrent implantation failure. That is a different topic on its own if we're going to delve into that. And sometimes I shy away from doing live with Cynthia because we don't seem to be able to bring it to an end.
Dr. Fache, there is always, it is always an absolute pleasure speaking to you. For just in summary, basically today we've talked about the ovarian PRP procedure that happens at Procare Hospital. I've seen a lot of people asking, is there Procare in Lagos? They've responded to, but please, if you want to know more about this procedure, if you want to know more about other fertility options that are available to you, please head to the Procare Hospital Instagram page. You can get their phone number on there, and then you can send them a DM. You can call at any time, book an appointment. Look, people come in from all around the world for medical tourism to Nigeria. It doesn't matter what state you are in. It's just Abuja is around the corner, especially when you'll be going to one of the best that is available in the world. What else is there to do? For those that one of the strongest points that Dr. Fache has tried to push today is that for those people who are probably considering donor eggs and the like, PRP is a very, very good option for you. So yes, thank you everybody who joined us. Dr. Fache, I don't know if there's something else you would like to add before I summarize this and wrap it up for the week.
I just want to thank those, who have joined for their time, and then encourage them to connect with us on our various social media handles. Like you have said earlier, we're going to have another session to address some of the questions in a week, and so we look forward to see them and see more people there. I appreciate their time, and we thank them for joining.